Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Well, welcome back, everyone, to another fabulous episode of Research Works. I'm so glad you could join us today. And welcome, Marissa. Thank you for joining us again in the podcast.
Thanks for having me back.
We do keep calling you back, so that's
I never
a good
mind.
thing.
It's
no,
good.
it's great. It's great to have you back. And it's like an all-in-person interview today, so we're very excited to speak to a very dear friend of ours, Sue-Ann Davidson from the Perth Children's Hospital. Hello, Sue-Ann.
Hello, and thank you so much for having me.
Oh, it's so nice to have you here. We've worked with Sue-Ann for many, many years in different capacities, and now that you've embarked on your PhD, you always knew this moment was going to come, and I think you probably were half expecting me to email you, and you knew it was coming.
I knew it was coming.
Yeah, you knew it was coming. I do keenly watch what people are up to with their research, and I always look at it for publications, so it's nice to have you here. But we should tell everyone, I mean, we know Sue-Ann really well, but let's tell everyone a bit about Sue-Ann, hey?
Very happy to.
It's a very cool bio.
It is.
Hold on to your horses, everyone. Here we go.
Sue-Ann Davidson is the manager of Kids Rehab WA at the Perth Children's Hospital and a PhD candidate at Curtin University. Sue-Ann has over 15 years' experience in the design, implementation and evaluation of tertiary paediatric rehabilitation services at PCH. Sue-Ann's experience in clinical, management and leadership has enabled her to lead improvements within the tertiary hospital setting to improve accessible, equitable and sustainable services for children and adolescents in WA. Sue-Ann has served on several committees, including the Disability Health Network's Executive Advisory Group and the WA Sustainable Health Review Clinical Reference Group. She's now the co-chair of the Child and Adolescent Health Service Disability Access and Inclusion Committee. Sue-Ann has a Master's in Health Administration and is a PhD candidate with her studies focusing on the development of a statewide early detection network for children at high risk of CP and neurodevelopmental disability, linked to national and international best practice models.
Wow. See, I told you. And all the committees you serve on, really long terms, like there's a lot of words in all of them, aren't they? Yes, and you can't just say the acronyms because no one will understand what they are. So you have to go through the whole thing. Well done, Marissa.
Well done.
Well, I didn't do the work. It's Sue-Ann's work. But thank you. I'm glad I could read it.
I think it's often a really good opportunity to serve on those committees because it really gives you the opportunity to meet so many interesting people across different sectors of the health and disability and other areas of our systems, and it gives you a different perspective to your work. So it's really a great opportunity to serve on those committees.
It's such a good idea, and I love that you've raised that too. I mean, before we get into the meat of the whole podcast, but you often do get opportunities to serve in committees, and sometimes it's really easy to go, I don't really have the time for it. But you do meet people that you would not meet otherwise.
Exactly.
And we all, as much as we don't want to be, but it happens, you get caught in your own silo because life is busy and it's hard to step out of that. So it's a very good example. Very, very good example. So apart from being, very good with your time, we also have an icebreaker question, which we always love to get to know people a little bit more.
This one's an interesting one because it has made me reflect a bit more. What's one thing you are unbeatable at, Sue-Ann?
Yes,
there may be more than one, but go for it.
Well, I'm just going to use an example that will make some people I know laugh or at least smile. I'm unbeatable. Every year for my birthday, I'm usually down south in my hometown, which is Esperance. And on my birthday, my treat to myself is to actually visit the Esperance Museum, which my family think are hilarious. And I always invite them to come, and most of them find a way to avoid coming. But I usually find either a new member of the family, might be a new in-law, a new girlfriend or boyfriend, or a niece or nephew of the right age. And I coerce them to coming. And, of course, they love it. And I have a link to the museum because as a child I was one of those very uncool children that was part of a museum group, which was really a natural history group. I love that. But the reason that I think it's really important is I think it reflects an innate human quality of inquiry and wanting knowledge and carrying that through your lifetime.
Yes.
And it's my sneaky way of getting a bit of history and knowledge translation, if I can really draw a very wide boat into my nieces and nephews. So they will laugh when they hear this, if they ever listen to this.
Of course they will.
But,
of course they will.
Yeah, so that's something that I'm unbeatable at, is probably boring my family.
I was thinking it sounds quite exciting.
Because when we were in Slovenia, I didn't get much time because we were recording a lot of episodes, FYI, 27, just in case anyone was wondering. And you were visiting lots of museums.
I went
and
to
you
the
were telling us
museum.
all about it. It was great.
Exactly. Wherever I go, I love to go to a good museum.
Good.
It's
That's
a very,
really
very good
good
way to know a place.
Yeah, it is.
That's a hot tip for travellers.
I love that. We should do it in our hometown. I haven't been to my hometown museum. I'll take you. Should do that. Okay. What about you? Good question.
I was thinking about this. Probably napping. I like to joke that my hobby is to nap. And whether I think this stemmed from having a child that initially didn't sleep that well, and I would nap. And now I joke, but it is my hobby, but also think I'm very skilled at.
She's actually, I can definitely give you all kudos to that one, because whenever I message you and I go, how was your day? It was great. I had a nap.
My family laugh because they're like, how could you nap? You've got so many, how do you wind down? For some reason, I can just nap.
It's quite a skill.
Yeah.
It's quite a skill.
Floor, really, wherever.
Wow.
Yeah.
That's actually brilliant. Okay, so my unbeatable skill would have to be, whenever you're a researcher and a clinician, you're often very, very busy. And everyone goes, oh, you're doing so much. You must be so busy. And I'm like, and I am. But I'm really, really good at, on the flip side, when I just want to chill, I'm really good at going from all in to completely nothing. And so I can watch a lot of TV episodes on Netflix. Like, you would be surprised how much I watch. What I'm also really good at, because I can cane through a lot, is I don't pay attention very well at all, because I'm just really using it as chewing gum to the mind. I just sit there and I do watch, but then I often have to rewatch the first episode or so because I don't know anyone's names. I'll get to the mini-series and it'll be 7. They're still naming people. I'm like, but who was that? I don't get it. And I'll persist, but I'm very good at not remembering names and really good at caning through lots of episodes. And it's actually quite terrible that someone who is meant to do a lot of work and write articles and all that kind of thing watches so much Netflix.
No, I think it's great.
I think it's great. It's what I'd call a goldfish moment.
It
round
is,
and round.
yes.
The brain is tuned out.
Yes.
Yeah.
And I often can't really describe what I watch because I do just sit there. It's the complete opposite, and I think that's what I do. But I'm very good at it.
You've given me great recommendations, so it's a skill I'm happy to encourage.
I often don't remember the names of them, but I'll describe it in some format. But yes, it's a good question because I think it's one that has allowed us to ponder. But let's get into the meat of this. Now, this is a very interesting title. And the reason why Sue-Anne was using all this really researchy words in there is because it really does relate to the article we're going to talk about today, published in BMJ Open 2022. And the article is titled From Guidelines to Practice, Gold. Gold wasn't in it, but I'm just saying it's gold. A retrospective clinical cohort study investigating implementation of the early detection guidelines for cerebral palsy in a statewide early intervention service.
Way too long.
It's terrible when the journals go, no, the title can only be 5 words or 10 words, and you're in a lot of trouble.
Yeah. But on the flip side, they often say you have to describe the study type and the population and all
do the
that
whole
in the
pico.
title. So, for goodness sake.
That's right. But we have a very good idea about what it is. So let's go through the abstract. So today we'll be talking about the implementation of an integrated knowledge to action strategy and how the clinical guidelines for the early detection of cerebral palsy in a statewide early intervention service and the impact of social determinants of health on service engagement. So in this retrospective longitudinal cohort study that was completed in Western Australia's tertiary paediatric early intervention service, knowledge translation strategies, which included consumer perspectives, clinician training, and communities of practice, guided implementation. With referral number and age, delivery of early detection and intervention following the implementation of the guidelines, it was found that the implementation strategies were effective in reducing referral age, with improved delivery of early detection assessments. So this has some very important implications on both short-term and long-term health outcomes. Impressive. It's great.
Now, just to get started, can we talk about, not where we're at now, but just going back, like you said, like the museum, going back in time. Historically, can you start by talking us through how referrals for CP have been, referrals for the diagnosis of cerebral palsy have historically been made in WA?
Historically, referrals have been late. And this has been true across many countries, I think, and across Australia.
Yeah.
But really the average referral age has been around 18 to 16 months, which means that diagnosis is delayed until around 19 months of age.
Wow. That's a long time in a child's life. It is. And a long time of worry, isn't it?
It's a long time of worry for parents.
Yeah. Yep.
Can you expand on that? Why, obviously, that is, we know that that's late.
Yeah.
And why is that such an issue?
Well, the early detection guidelines that have been published say that we can use standardised motor and neurological assessments now and a clinical history to predict high risk of CP really early, actually from as early as 12 weeks corrected age.
That's really incredible.
And there was a systematic review, which a lot of people will be familiar with, done by Novak and colleagues published in 2017. And it showed that the best tools that you can use for children under 5 months of age are general movements assessment, the Hammersmith Infant Neurological Examination or the HINE, and a term equivalent age MRI of the brain. So we can do this now very young, and we should. And then if children are over 5 months of age, there are different assessments that can be used as well. So we've got the tools and we've got the knowledge now to do this. And it's a matter of awareness of parents and clinicians to facilitate early referrals so that this can be done.
Yes.
The flow-on effect of that is huge, which I think we will touch on more further down.
Indeed,
But you're talking, like you said, 6 months compared to 18 months. That's huge.
That's a big time difference. And when you think about what happens during that time in the life of a child, there's so much development that happens there.
Exactly.
And then all the missed opportunities, the heartbreak, I think. Missed opportunity is one of those things that you never want to – it's so hard to feel regretful if you haven't used that time well.
Exactly.
And it really comes down to all the knowledge we have about early intervention. So let's just summarise that a little bit. I'm sure that forms a big part of why you've done what you've done is to look at that the opportunity for early intervention. Why is early intervention so important?
Well, firstly, I go back to the fact that it's a human right, fundamental human right to have the opportunity to develop to our full potential.
Yes.
And I think this is not only good for individuals and family, but for all of our society. So that's really foundational. And then we need to think about the first 1,000 days and how important they are. And we should really use that window of opportunity to capitalise on the cognitive and motor plasticity that is happening and there's a potential for during that period of time. And so given that and given the early detection guidelines stating that once we've detected a high risk of CP, we really should refer promptly to early intervention. And then by doing that, children and families have that opportunity to optimise that motor and cognitive plasticity and also to prevent or minimise the complications that can occur in a secondary way to the normal development or the typical development of children, but children with cerebral palsy will develop differently. And also, really importantly, to access parental support. So that's really critical.
That's a huge, absolutely huge part.
When you said the first 1,000 days, I feel like that's a term that has been really coined around a whole lot more these days. Why the first 1,000? What do we know about the first 1,000 days?
We just know what an explosion is happening inside the brain and that early brain growth and the neural connections that are being formed and the rapid growth and then a period of falling away and pruning of connections that are actually not used. So if we don't establish those pathways or at least facilitate their establishment and optimise them as much as we can in these children's brains, we really risk not using what we could potentially use.
That's right. And I love that because it's not just about the go-to often is the motor development, because that's often the motor that is assessed. It's the first thing that might be noticed. And, but it's also in those first 1,000 days where, we've spoken recently with other researchers about parent relationships and attachment theory. And I love how you talked then about, supporting parents too, because that's a critical part to early intervention, isn't it? It's much broader than a motor outcome. It's things that set people up for life.
Exactly.
Yeah.
Exactly. And we know from talking to parents that they generally know something is not right with their baby's development or movement.
Yeah.
And this causes so much distress.
Yeah.
They spend a lot of time searching for answers.
Yeah.
They talk to each other, they talk to their family, they talk to their friends, and then they also often will go and seek alternative health practitioners. And Dr. Google, of course scarily present in people's lives these days. Yeah. And then we also know that families and carers of children with cerebral palsy have actually quite high rates of anxiety and depression and poor mental health. And we would hope that providing early support related to early intervention for children really makes a difference to families and the environment that children can grow up in.
I love that. And, it's so true, isn't it? If there's a vacuum there and things are evidence-based, things we know are really important aren't implemented, at the end of the day, people know they need to find some help somewhere, and whoever is willing to give them help, you'll naturally go there because you need support, and it's so vital. And I'd really encourage people to go back to everyone's probably heard it because it's like our probably most popular episode with Kathy Morgan, when we're talking about early intervention principles, all the evidence-based summary, systematic review. It's so great. So please make sure you go into that, because that goes into everything that Sue Ann has spoken about in more detail. Yeah. Okay, so we've set the scene for why it's so important and early detection is possible. And this is Q Sue Ann. Come on in. What is the objective of your study? What were you going to do about it?
Right, well, we had two objectives.
Yes, good.
We wanted to measure both the process of implementing the guidelines.
Yeah.
And this was slightly different because we were doing it in an existing early intervention service that spans the state of WA. Yeah. Meaning not that we provide services from the north to the south physically, but that actually we get referrals across the state because we are the sole tertiary centre that provides these early intervention services and the early detection service. But so we wanted to know if children were being referred sooner, whether we were actually using the right assessments at the right time, and whether we were actually providing intervention early. And then because WA is such a large state and it's got such a large or varied distribution of money and power, resources, the geography is so varied, we really wanted to see whether that impacted access and engagement with services and whether the social determinants of health also had an impact there. So that was our other main objective.
I mean, those are big questions, but they're actually they're crucial questions, because if you don't, I can imagine a lot of people living in their countries, and if you want to look at whether it's worthwhile headed down a certain path or implementing something, you actually need to know the current state and then therefore how you build on that. So it's a kind of understand where you started.
Which leads me to my next point, because we want to know how this was done and how do you go about it and what are these phases. And so can you explain a bit more about the integrated knowledge to action framework? What is it and how did you go about achieving this?
Sure. Well, the integrated knowledge to action framework really has two main parts. The core of it is knowledge generation, and that's really where you need to start.
Yes.
And then the other bit is how you use that knowledge and translate it to your local context.
Yes, great.
So we used the knowledge that was generated by the systematic review that I referred to later, which resulted in the publication of the early detection guidelines.
Yes.
And we wanted then to translate that to the PCH context for use.
Yep, okay.
So this retrospective longitudinal cohort study, we split it into phases to do this. So we started with a 12-month pre-implementation phase where we just had said this is our baseline existing early intervention service for 12 months. That's our baseline. And then from a project perspective, we had 3 phases, very, very creatively called A, B and C.
Oh, great.
Clever.
Yeah, that's good.
Straightforward.
Keep it simple. So each of them was 18 months long.
Uh-huh.
And because it was happening in a real-world, real-time clinical service, many of the activities are overlapped or happened in parallel.
Yeah, okay.
But the main focus of each phase, I can let you know, was firstly during phase A, we really developed the model for the at-risk CP service, and then we adapted it to our service context. And we had consumer input and focus groups, which helped us do that, which was really important.
Yes.
And then in the next phase, we assessed and addressed the local barriers to knowledge use. So what we found is that we needed to do some more training about the standardised early detection assessment tools. So we provided training in tools like general movements, in the HINE, in the hand assessment for infants or the HI, in the IMP, which is used to assess speech, and for a variety of other tools and assessments for children and babies. And so we offered that training to our clinical team, but also opened it up more widely to clinicians across the state who work with this cohort of children and families.
How did you go about contacting those clinicians? Was it through the major hubs or?
Really, a lot of our clinical professional networks, a lot of advertising, this course is coming up, are you interested in attending? We were also part of the, can't remember the acronym for it, there's so many acronyms, but basically the Australian Cerebral Palsy Clinical Trials Network.
Oh, yes.
So that was a fantastic resource because that actually had training that was available and that we made sure, then we were able to make sure that our clinicians and other clinicians that worked with this cohort of children and families were aware of opportunities and we could link them in. We could host the training on site and online.
Wow.
Great. Get it out there.
That's huge. That's a lot of training. And was it mostly in person or was it online? Like what was the main medium for that?
It was really... it was a mix of both. We funded some of our clinicians to travel to the East Coast to attend some training that was in person.
Sure.
And we hosted some in person on site as well.
Sure. Yeah.
We did also have then the opportunity to have some train the trainers, and so we sent them out to train in regional areas, and that's still ongoing work that we do. And then we were also able to facilitate the first hybrid online and face-to-face general movements course with some of the instructors beaming in from Europe, some from the East Coast, and then some in person that attended from the East Coast to actually do it. So it was a very mixed bag, and it needed quite a lot of resourcing to do that, which definitely wasn't all done by me. There was, as usual, there's a huge team that did this work.
Yeah. I think that speaks to the importance, kind of going back to the committees thing we spoke about, it's actually being part of big networks. You know, big research is never done on your own. It really isn't. And why would you? It's much more fun with other people.
Exactly.
But it is networks that allow you to, otherwise you are duplicating. Like there's never going to be enough resource to do all of that.
Exactly.
But that would have been quite a big effort during that time. How long did that time sort of span? Is it kind of like an ongoing thing, or at this particular time when it was being put into place, was it a very specific period of time?
We really tried to keep this training and education rolling over the whole period of the study, and we now are continuing to offer training either by clinicians who are acting as experts now themselves and able to provide the training, or we have various funding bodies that will support us. So the PCH Foundation is one of those bodies that have been very generous in their support, and our current money from them is supporting some outreach to the Kimberley where we can provide training and education to keep this work going.
So the reality is there's a decent investment that is required and find these resources, but coordinating your efforts. And the framework really, though, helps you to look at those phases where you need those resources. I feel like that's a real strength of it, isn't it?
Yes, absolutely.
So you talked through phase B, so training those clinicians. Can you talk us through now phase C and what that involved?
Yes, so phase C, a lot of that continued on, but we also focused on, now that we have people trained, are we actually using the right tools at the right time? And then also, are we using the right interventions for the right children as well? And really importantly, the other bit we did in phase B was to review and set up and improve our data collection processes. Can't forget data, very important. And so then by phase C, we were able to use the data and use it for monitoring and evaluation. We had a lot of our trainees and different clinicians doing audits of the service to review how we were tracking and what we could improve.
Interesting. So that's how you were able to assess whether it was done at the right time and the right intervention. I'm curious about how, intervention is often so hard to define. How did you do that evaluation to see whether it was the right intervention? What was the right intervention and what was the not right intervention, I guess?
It's really hard and it's ongoing work. The short answer is that we set up a number of working groups, clinical working groups, with clinicians from the early intervention service who had focus on different areas. So one of them was a focus on goal setting. And how do you actually conceptualise goal setting with parents or caregivers of a child who's still a baby, newly diagnosed with cerebral palsy, very overwhelming? How do you have that conversation? What sort of goals do you set? What sort of tools do you use to measure? And how do you communicate that amongst the multidisciplinary clinical team? I don't think we've got it perfectly right yet. However, it's really important to have the clinicians in the service leading and continuing that work, because that's how we continue to improve all the time.
That's fantastic.
So, Anne, can you tell us a little bit more about over what time period did this study start? When did you start that phase A? What year was it?
Very good question, because this takes a long time to do this sort of work.
I can imagine. Experience. Fair enough.
So our pre-implementation reference period was actually the 12 months between the 1st of July 2014 and the end of June 2015.
Right.
And then phase A was the 18-month period from the 1st of June 2015. And then each of those 3 18-month periods actually took us up to the end of December 2019. If I have my maths right. So actually we're looking at, I think that's something like a 5.5 year period. So this takes time. And I think part of the time frame, the importance of that length of time is that it gives you time in a real world clinical service to implement change. And that's a whole podcast on its own, of course.
I think so. Wow, that's impressive.
I always describe it as the messiness of clinical work, and I don't mean that in any way in a bad way. It is real life, and if we're going to translate knowledge and change things, then we need to be flexible and adaptable and use and take time to do it. But on the flip side, we want to do it as fast as we can because we know that knowledge to translation gap is, anecdotally 17 years. That's way too long.
It's too long.
These children are adults by that time.
They are indeed. And I love how you described all of that too, because I think, doing research within a clinical setting is beautiful in its own way, because hopefully knowledge translation does occur as you're doing it. But the priority is always going to be patient care and safety. And that's always the priority, whilst also making sure that the data, whilst might be a bit secondary to that, is clean and it's usable data, or we're not going to collect the right information to then change practice. So it's a fine balance. But of course, you can do it.
So over this 5-year time frame, can you tell us a little bit about who was included in this study?
Actually, there were 3 groups of participants. So firstly, the parents of the children referred were invited to participate in focus groups.
Right.
And that was really to tell us what was important to them when we were designing the service. And that was really in the early phase of the study. And then it was clinicians who work with children and families. And they were really included as part of our assessment of who got trained and the training and education. And then, of course, the main participants were all the children who were referred during phases A, B and C and the reference group in the pre-implementation phase. Their main exclusion criteria was really that if children were referred when they were more than 4 years of age, then we didn't include them. And that was really because we do have children with CP, obviously, that move around.
Yes.
And often those children are referred, but they already have a diagnosis, and it's really just sorting out which of the clinical services are appropriate.
Yeah.
And a little bit of historical lag from the way our service was originally set up to the new service.
Yeah.
I love how there was very little exclusion, which means you capture everyone in that early intervention year group, which allows you to identify those barriers and you know, what are those things that can be improved on. So
yeah, fantastic. Okay, so the all-important outcomes and the type of data that was being collected. Obviously, you said this was retrospective, but let's go into more details about what you actually collected.
Sure. So there are a few groups I've put them into. One was what I would call clinical implementation outcomes, because I think it's important when we're thinking about this sort of work that we think about implementation metrics and clinical metrics.
Yes.
And then, of course, I also had some of the social determinants as well.
Yeah.
So the implementation metrics were things like how many clinics did we run, how many clinicians did we train, how many research trials were we involved in, what were our numbers of focus group participants. So those sorts of implementation metrics, I call them.
Yeah, yep.
And then clinically, we measured things that people would be much more familiar with, I suspect, would be things like corrected gestational age at referral and at first appointment. And then we split that down into whether it was a medical or an allied health appointment.
Right.
You can get as granular as you like.
Wow.
We looked at the timing of the MRI, GMA, Hein assessments.
Yes.
And we also then split it into whether their age at assessment, so under 5 or over 5 months of age, to check which pathway they were on and how that differed or if it differed. And then we looked at the outcome of whether they did have a CP diagnosis and what GMFCS level they were if that data was available, because obviously some of them were still quite young.
Yeah. So curious about all that data that was being collected. How, was it collected, like was there already a database that all of this information was stored? Did you have to go through and find the data? Like what was involved with that?
So we're really fortunate in that we have a database which does an existing database which collects data across all of our rehab programs.
Yeah.
So we were already collecting a little bit of data in the early intervention program, but nowhere near at this level of granularity or specificity.
Yeah, sure.
So we, through some grant funding, we had some funding to increase our data collection capacity within the database and develop it. And I think that's really important when you are applying for grants like this to implement change.
Yes.
That you have you build in capacity to collect your data, store it.
Yes.
And then you can use it with the appropriate ethical and governance approvals to look at aggregate data.
Yeah.
So our clinicians use it all the time to look at single view of a patient, but we can use it for quality improvement and research at an aggregate and a de-identified level, and it's really useful data.
Yeah, fantastic. And just another question on that before we start going to your outcomes. The results of it. You talked about social determinants. How is that collected and what's involved in that?
So we had a few metrics that were pragmatic to collect. There's lots more you could use.
Yeah.
One of the forms that we used an adapted record, which is called an ACE checklist, or an ACE stands for Adverse Childhood Experiences.
Okay. Yep.
And this was a form that was developed by a team in southwest Sydney, some work led by Sue Wolfenden and her colleagues.
Yep.
And that was really looks at things that impact the child's exposure to in the home environment, drug use, homelessness, poverty, those sorts of adverse childhood influences.
Sure.
Then we use the Australian Bureau of Statistics measures, one of them being the Socio-Economic Index of Relative Social Advantage and Disadvantage. There's a mouthful.
Yeah.
Wow.
It's more commonly known as a CEFA quintile, and essentially the population across Australia, and we just use WA, is sliced into quintiles of relative social advantage or disadvantage.
Okay.
And so if you're in quintile 1, you live in the most relatively disadvantaged area, and quintile 5, the most relatively advantaged area, socioeconomically.
Okay.
And then we also used a remoteness index from the ABS as well, which looks at geographical remoteness.
Right, okay.
And the last thing that we used was a measure was your did not attend appointment, so your DNA rate.
DNAs,
did you actually turn up to appointments you were offered?
Sure.
Yeah.
That's really interesting. Thank you.
Now, who was included? So you've got this massive database and then you've pulled it all together. Can you tell
How
us?
much data
I'm
did
sure
you
there's
have?
a lot here to go through, but can you kind of summarise for us who was included?
Yeah.
Sure. So from just some brief results about the clinical implementation metrics.
Yeah.
So we had 10 parents who participated in focus groups. We trained about 100 clinicians across WA,
Wow.
which was a really good start, and of course we want to keep that up.
Yes.
We were part of 6 multi-site research trials, part of that clinical trials network over that period of time. And 64 of 132 children who were eligible to be enrolled in studies were enrolled and were part of those trials. And I think at last count we had about 14 quality improvement audits or projects done during the period of time. So that's some of those implementation metrics.
Wonderful. Jeepers.
And then as far as the children who were involved, there were actually 511 children referred that were under 4 years of age during this period of time.
Wow.
So just over half of them were male. 58% of them were born at term. And we did keep a track of the children who died during the period, and only 8 children died during that period, which meant that we had 494 children then that we were able to start our analysis of their appointments and assessments and all those sorts of things.
Yeah, great. That's a huge number.
That is such a big number. And just for a bit of background, the reason why I laugh every time Sue-Ann talks about data is because Sue-Ann is really well known for data. Back when I was working with Sue-Ann, every time there was a data question, it was like, go see Sue-Ann. But, that's why you're so well suited for this, because it's just that database, what is in the database and how you then use it is just so important, isn't it? So if we go into the results now, like you talked, I like how you separated the different areas of what was being done. So we talked about the clinical implementation. Can you walk us through all of the results that you found now? And I know there's a huge amount of statistical analysis for that. I mean, do you want to talk about that in brief? I read it and went, oh, that's complex. But do you want to just maybe describe that first? Because it's pretty amazing.
Of course, I had a lot of help doing the stats. Don't think that I did this myself. That's one of this, amazing team. Well, we use pretty simple descriptive statistics for our clinical implementation metrics, and a lot of the clinical outcome measures as well, like our demographics, of course.
Yeah, sure.
And then to measure change between phases and compared to our baseline, we used chi-squared tests or Fisher's exact if the expected cell counts were low. And then when we look for associations between the CEFA quintile and remoteness, DNA rates and childhood adversity or ACE scores, we use logistic regression and negative binomial regression. And I definitely got advice about how to interpret and analyse that. And it made sense. It was good.
Yeah, amazing. Okay, so what did those statistical tests tell you? Because that's always the fun part when you receive that back and interpret.
Exactly.
It's fun.
Well, I think using that integrated knowledge to action framework really facilitated effective implementation of the guidelines. So we expanded our clinics. I've talked about how many clinicians were trained. We were really part of research trials, and it was embedded in clinical care. So that was the really key learning from that. And I think also importantly, our families and consumers informed the process of design and implementation. So our clinical outcomes were really amazing. We did implement this in this statewide early detection or early intervention service, and we reduced the age of referral for infants at risk of CP from a median age of 16.1 months corrected to 5.1 months. Wow. So that was really a significant change over each phase, and obviously compared to the baseline as well.
That is amazing. Has this been done anywhere else before that you've seen reported? I mean, that's such an incredible reduction in time.
Yeah, I think that there's been a lot of other work and a lot of other really good work that's been done in various places around the world in Australia, and And this work does reduce the median age. It's probably a little bit lower than some of the other reported ranges. But we've looked at it since that time as well, and we've been able to maintain that, and we even bumped down a little bit lower in some of our reporting periods as well, which is the other really important part to change like this, is you've got to keep looking at it over time and make sure that it wasn't just the excitement and the enthusiasm of the research phase. You have to be able to sustain that past the end of the project.
But I love that the fact that you involved so many people across the service, the buy-in is there, and therefore the additional skills are there, because there's a lot of skills here. Not anyone can just do a GMA. Like you do need to do it properly.
That's right.
But now you've got this whole network that will sustain it for hopefully generations to come. That's the hope of this, isn't it?
Absolutely. That's our really important next step, because it's important to remember that this work was focused, the main focus was within a tertiary service.
Sure.
But WA is a big state.
It is.
And there's a lot of workforce change within the service at PCH, let alone more widely across the state.
Of course.
And so our next work is really progressing towards establishing that statewide network so that it's sustainable for the long term.
And is it also about sustaining it without needing additional grant funding? Like, is it so that's actually integrated into the healthcare service?
That's right.
Yeah.
I think we need to find a way to join up all of the really good pockets of work that are being done elsewhere, because so many people recognise this gap and this need, that there are pockets of good work being done, and we don't want to reinvent the wheel.
Yeah.
And also to set up a system so it's easy for people to do the right thing in as far as detect early and refer early on a clear pathway to early intervention.
Yes.
And we also want to make sure this phrase that there's no wrong door. So families or clinicians that raise a query, again, it goes back to that clear referral pathway. Whichever way you start on it, you get redirected to the right way.
Is that why when you described how many clinical trials you're part of and all the things that the hospital as a whole, the service as a whole is doing, do you think that's why the results were what they were? Like, do you interpret that as the overall engagement and buy-in of everyone about wanting to make a change, or do you think there's other factors that are involved with it?
I do think that families and clinicians are really passionate about making a change because people recognise how important those early years are, and people really want the best outcome for children and families.
Yeah.
But often our systems work against us, and that could be our information systems, our communication system, the way our clinics are structured. So I think we need to really look at the way that our systems are structured and make it easier for the right thing to happen for these children and families.
Sure.
And just to acknowledge how huge that change is from 16.1 months to 5.1 months. And you talked about the impact of the parents and, parents' anxiety in those early years if they've got a baby and, they might be noticing a motor change or they've had a trauma at birth or something that's giving them to get an answer, as hard as that may be. And obviously I don't know what that might be like, but to be given an answer and then to be able to be supported through that with parents. Have you had any feedback on that from parents about, being given an early diagnosis and then given that support?
That's some work that we are progressing now. So I think what I would probably comment on related to that is that change has actually driven clinical change that I hadn't thought about or predicted.
Sure.
So it's changed. It's had a flow-on effect. It's had a flow-on impact on our services. So with a child who's diagnosed with cerebral palsy, comes through our early intervention service, they will then often be referred on to our cerebral palsy service. So now we have a cohort of children and their carers or parents coming through much younger.
Yes.
So their needs are slightly different to the traditional 4 or 5-year-olds we had before. They're at a different stage physically and emotionally and in that journey. So that's changed the demand on the service. And we've adapted. We have groups for parents now to meet some of those psychological and mental health needs and just the wider support needs. So it's had a lot of flow-on impacts to our clinical service that we're still working through and improving as we go.
It's quite incredible, though, that if that can be provided to a family so much earlier, just simply a year earlier, Amazing.
And the challenge to that as well is because you did it so quickly is having all the services in place ready to go now, right? It's
right.
Not just within the tertiary setting, but what that also means in the community and having services ready to take that up. You know, we always hear about lengthy wait lists to get into services. But if you're going to make a significant change, it's a good change, it's also the flow on of all the other structures in place.
Of course.
Yeah.
I think the other important context for all of this change, of course, in Australia and in Western Australia was the introduction of the National Disability Insurance Scheme.
Yeah.
So that really changed the landscape for community-based therapy providers and the way that referral pathway out of our early intervention service from a therapy perspective. And as you mentioned, the wait. So navigating that has happened in parallel with this change.
Sure, yeah. In an ideal world, what would you want that to look like? What would that look like to you? From tertiary, early to community, I think what we've got now is great, but we always have an ideal, don't we?
We do have an ideal. I think timeliness is really important for children and babies.
Yeah,
once the families are well established with understanding the diagnosis and the immediate therapeutic and medical needs have been met and the families are now ready to access care closer to home, which is usually in the community, it's better for them, then to be able to refer to the right provider who's close to home without a wait would be ideal.
Yes.
I think there's often a need for ongoing tertiary review, and so we need that communication pathway to be very smooth.
Yes.
And I think from both a clinician but especially from a family perspective, continuity and coordination of care are key. They make such a difference.
Yes.
And we haven't got that 100% right yet, but we're working on it.
Yeah. I mean, you can just imagine how that's a beautiful thing to look forward to is you can imagine having, you know, if you had the resources, to have someone that can facilitate, like a case manager of some sort that can facilitate that process, but not just refer to community and go, okay, that's where it stops. It kind of goes into the community for a period of time as they access the right services and then how that coordinates back to the health system. And a lot of things need to happen, but that's a good thing to aim for. Yeah.
Now, I want to touch on, because obviously the power of your study and looking at data over a long period in real time is that you can identify real barriers, which allows you then to make, I guess, meaningful change on how that can improve. You touched on remoteness, and we know WA is such a huge state that's a barrier for early detection. Can you talk about some of the other barriers you found?
Sure.
Yeah.
So I think living with social disadvantage is a real barrier to accessing care.
Yeah.
So we really found that children who lived in the lower socioeconomic quintiles were more than 2 times likely to miss their appointments.
Wow.
They were up to 4 times. The lowest socioeconomic people living in that area really were up to 4 times more at risk of exposure to childhood adversity. So these things really have an impact on children and babies, and we might not be able to change, as a health system, we probably can't change where they live. However, we can adapt our services to try and meet different needs for different cohorts.
Yeah, that's really important.
So I think that is really important when we're thinking about our population, because the other thing that we found was that the children who are referred to our early intervention service are actually more at risk of living in areas of lower relative social disadvantage or compared to the rest of the WA population.
Sure, okay.
Which is a really interesting finding.
Yeah.
And it does back up some other research that's published where children with cerebral palsy who are more severely impacted, so higher GMFCS levels, also are more exposed to relative social disadvantage. So there are some key consistent messages coming through here.
Yeah.
Did you touch on before as well that that's where you're kind of headed from here, is looking at how you can address some of these barriers? And
That's right. So at the moment, some of the work we're doing is interviewing parents of children who didn't get to see us by the time their baby was 6 months of age, so they weren't referred early.
Wow.
And just asking them what happened in their journey, so what happened when the baby was born and what that looked like and how they finally did get to see somebody and have a diagnosis made and get therapy.
Right.
And I'm in the process now of interviewing clinicians and really asking them the same thing. What do they think the system and the health service barriers are to early detection and early referral across the state?
It's great.
I love this so much because you're going right to the front line to really be able to evoke change. And I think, that's amazing.
And as an overall model, framework, I should say, as an integrated knowledge translation framework, you can see how it was used here so beautifully to guide the process of what to do, and it's so lovely. Do you have any hot tips for anyone who wants to translate, current research into practice? This is obviously done at a big statewide level, which is really, truly incredible. But there's often, you can do it on a smaller levels at different organisations to implement it in. Do you have any hot tips of what you would recommend, where to start, what to do?
Yeah, sure. I mean, I think be systematic, and I think be systematic in your approach, but also systematic in that you need to think what I call wide and high. And use a framework which helps you, because it helps you design what you want to do. It helps you communicate what you want to do, and then when you're doing it, what you're doing and why you're doing it.
Yes.
And obviously it helps you monitor and evaluate it. And actually you might even find that you improve the framework as you go along.
Yeah,
you never know.
Wonderful, yeah.
The usual things about involving all the important people.
Yeah, sure.
So
important.
All the people doing the work, all the people supporting the work, including the people paying for the work. So, our philanthropic funders are really important because they enable this work and they often facilitate the startup work or the pilot work.
That's
so they're really critical.
Yeah.
And also the people being worked on, in inverted commas, which really is your patients and your families, but also your clinicians. So everyone needs to have a voice in this for it to work. And I said before, think about two types of outcomes, the process and the intervention outcomes.
Yeah.
And don't forget data.
Don't forget data.
Please don't forget data.
Never forget data. I love that process and the outcomes. That's actually really, really important and often missed. But that information you provided was really, really interesting, and you can see how you could use that to shape what it's currently doing, what's happening for the future. So good.
I think probably the other bit I'd say there is tell people about it. So really, really a bit of an ad for obviously this as well. Shameless ad. But if it's not communicated, it's not done.
Yeah, that's right.
So,
yes.
Well, this is all knowledge translation, isn't
it?
It
is,
We're
absolutely.
getting it out there.
That's right.
We're knowledge translating the knowledge translation framework.
Oh, that's too much.
Do you want to go into that?
That's not.
Oh, so nerdy. But we have not finished yet. Okay, so to wrap this all up, we're going to go to the most popular segment, as people often say to us. We're going to go to Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening on this episode. He occasionally takes notes as well as he listens and ponders about what's being discussed. So before we get into that, Sue-Ann, in about 60 seconds or so, if you could summarise the work that we've just spoken about. And Ed, there'll be time for a question. Take it away, Sue-Ann.
Thank you. Well, I'd like to say that it is possible to detect infants at high risk of cerebral palsy much earlier than we did in the past. Parents want us to do this, and they want both practical and psychological support and information for them and for their baby. So as health and disability service providers, we've got a role and a responsibility to do this. Indeed, it's a human right to have the opportunity to develop to your full potential and to give all people the opportunity to contribute to sustainable societies. Using knowledge translation frameworks is an effective way to do this. And I used the Integrated Knowledge to Action framework, and I found it was good. And the whole team found it was good. Using a framework is important. There are lots out there. Find them, review them, test them, and improve them if you can.
Sue-Ann.
That was great. So
inspiring.
Good.
So inspiring.
All right, Ed, over to you.
I've loved this conversation, just like I love every conversation that I get to sit in on.
We have great conversations.
Yeah.
And
obviously the early intervention thing, and I've learned so much over the past 3 years about what that looks like and how the research kind of contributes to that. And I love the whole frameworks and models giving that structure and helping things kind of come to fruition. And I'm going to go slightly off tangent here. A couple of episodes ago, we had the amazing Professor Iona Novak on the show, and she spoke about stem cells. And given obviously the what is currently available in Australia and stem cell technology, and I guess those kind of treatments aren't, where does that sit in the grand scheme of all of this, and how does that figure into the early intervention part?
That's a pretty, well, it's a good question. It's also, I think, a pretty mean question, Ed.
Sorry.
No, that's okay. You can edit that bit out. Look, I think it is a good question because it raises that wider question, and I talked about thinking wide and high, and I think Iona really is so good at doing that, and the way that she is able to stretch that research focus so wide across so many areas that influence the development of cerebral palsy, or why. Like, we still actually don't know why most children have cerebral palsy.
Okay.
And so it's part of that wider work in researching where it starts and to help families and support families to understand why their baby has cerebral palsy.
Yeah.
And that's, I think, a really important part of the journey for families.
Yeah.
It doesn't necessarily change our early detection tools. It may change our intervention, but that is all very important still. But it's like going back to even before that to help families understand, why did this happen and why did it happen to me? And I think that's probably really important across all families, and maybe in some cultural contexts than others as well.
It's a really good one. And yes, it was a big question, Ed, and Sue-Ann well answered. I think that if there is early detection, and if there's the possibilities of stem cells and the great hope that does lie within a lot of the treatments that are on its way, is that you can intervene far earlier with stem cells. And we know it's an anti-inflammatory. So if we can start even earlier, it does change the trajectory.
That's right.
So the earlier we can detect, that continues to be really important because our treatments rely on it, as with everything. Yeah.
I think the other part that's a really important part of these questions and these discussions are going back to the fundamental value and the value of everyone.
Yeah.
So, yes, for some people it's really important to look for a way to cure cerebral palsy. However, there's a lot of people that don't necessarily want that as well, because everyone's important and valuable.
That's right. Yeah. Good question. Big question. Lots to think about. It's like with Daniel Navon's podcast, was that he asked far more questions than we could answer. It was really great, really deep. But a good note to end on. Thank you so much, Sue-Ann, for coming in, having the chat with us and sharing your work. It truly is inspiring, and I watch from the sidelines what it is that you've been doing over many years, and I just absolutely just appreciate you so much, and so does the industry. So if you want access to this article, it is open access. We'll put a link to it on our website, researchworks.net. And of course, if you want to keep this as part of your PD requirements, there's a CPD form there that you can fill out to keep it there for you too. So, but for now, we'll say thank you again. Thank you, Sue-Ann.
Thank you.
Thank you. And thank you also to the amazing team I work with, my amazing supervision panel, and to you two, sir. You three, for being such an amazing interview panel. Thank you.
No, it's been our pleasure. So, we'll talk to you all again next time. Have a really good week, guys. Bye.
Bye.